All right. Well, welcome everybody, and thank you for joining us for what is now the 8th annual Puri Lecture. We're very excited to have an outstanding good friend and colleague as our guest here, but I want to set a little bit of the table, if you will, on the impetus behind how we got down this road years ago, and then introduce Dr. Puri to give a little bit more color commentary, if you will, on the family and what I think this all means to her and to them as well. So I'll start off. In fall of 2004, I met a 66-year-old gentleman who was Mr. Puri. He was diagnosed initially with mantle cell lymphoma, got initial treatment, including a transplant, and had a remission for 8 years. His lymphoma came back. He was subsequently treated with a couple of treatments that were developed actually here in terms of their phase 1 and phase 2 development, but ultimately ended up dying of a complication of either treatment or the disease itself. So that's the scientific version of the story. But the human version of the story is I was fortunate enough to meet a family in 2004 that was just incredibly kind and warm and generous and became a part of our Emory family, our Winship family back in 2004. And through the kindness and generosity of the family, we've been able to keep that relationship going even after Mr. Puri passed on. And that really is the power, I think, of the opportunity that they've given us and of this lectureship itself, the ability to continue that incredibly warm relationship that I and others on our teams have had with the family, even beyond and through that memory of that warmth and kindness, which is, to me, honestly, so much more important than the scientific stuff that I told you at the beginning. We're trying to make the cancer world a better place, and we couldn't do that without the support of the family. So I'll bring up Dr. Puri to talk as well now, to give a little bit more information on this, but that's at least my version of a little bit of the background. Dr. Puri?
Thank you, Dr. Loniel, and welcome to 8th annual Surinder K Lecture. And I'm so glad that we are here in person and we can see and feel all the friends. I appreciate that what Dr. Loniel has said. I'd like to give a little bit introduction to my husband. Besides being a patient, he, as Dr. Loniel said, was diagnosed in 2004 out of blue with stage 4 non-Hodgkin lymphoma. Only symptom he had was a little droop of his left eye or right eye, I don't remember. And then, of course, he was diagnosed with stage 4 non-Hodgkin lymphoma. And as scared as we were, as devastated as we were, we tried to figure out where and how to get treatment, the best treatment. And one of my dear friends, an ex-professor of pathology at Emory, who's a common friend to Dr. Loniel and I, told us he just had the right person to treat him. And that's where our fortune brought us in the hands of Dr. Loniel and his team. And I believe that Surinder got state-of-the-art, best available treatment, which allowed him to have total of almost 12, 13 years of post-diagnosis life. And he enjoyed his life fully during treatment. After treatment, he was doing everything he loved, being a consummate professional. He came to Atlanta with the company to start the MARTA system here, and I see his fingerprints on many things here. He was a wonderful husband, a great father, and a wonderful friend. Anyone who ever crossed paths with him always felt that he was the warmest, friendliest person who was very kind. And of course, he developed such a wonderful relationship with Dr. Loniel and his team, and many of his team members are here. And I think, got the best treatment. I'm very grateful to Winship. I have had a long relationship with Emory. I was a resident and a fellow here, was on faculty for a while, and then I was a breast cancer patient survivor here 30 years ago, and got wonderful treatment. I'm still here. And so I'm very grateful. And once we lost Surinder, we didn't know how we could thank Winship, the team, and how we could keep his memory alive. And we came up with the idea of this lecture. And the goal was really a humble one, to bring in researchers to share, collaborate, so that we could just keep promoting treatment of non-Hodgkin lymphoma, but other malignancies too, so that they become chronic diseases and not death sentences. And I think that it has been just a wonderful experience, and I can't thank Dr. Loniel enough for helping us through this and continuing with us. Now, I do want to welcome Dr. Rajkumar, another great speaker, researcher, and overwhelming credentials and overwhelming kind and number of awards you have. But I think that one thing that struck me a lot more, that you are also addressing another part of care of the patients, and that is challenging the pharma for inflated drug prices. And I'm just so excited that you're doing that, because if we don't have the money and the access to the treatment, I mean, what good is research and all the drugs? So thank you very much for doing that. I'm so excited. I do want to thank Dr. Loniel, as usual, for all that he does, and Jennifer, who has supported me through this and navigated this whole thing for us. So thank you very much, Jennifer, and welcome you all. Thank you.
All right, thank you very much. And as Dr. Puri alluded to, this is the 8th annual Puri Lecture, and for the previous 7 speakers, we have focused on lymphoma. For this one, we're going to change things up a little bit and focus on the more mature version of a B cell. I like to call it the James Bond of the B cells, if you will, as opposed to the infants and the teenagers, which are many of the lymphomas. We're very fortunate to have Dr. Rajkumar here today to join us from the Mayo Clinic, and I could spend an hour just going through his CV and all the accomplishments he's achieved in the myeloma field. But I think one of the things that really has struck me as a community is that we all do tend to work very closely together. And through that closeness, you work together, you get to know each other, you get to know families, you understand where people are coming from. And that's really what I think makes the myeloma community such a family. And Vincent is an original member, if you will, of what we kindly call the Indian Myeloma Mafia. There are about 8 of us. But even more importantly than that, his work has included new therapeutics, clinical trials. He leads the ECOG myeloma group, and just 7 years ago now, redefined myeloma, what it meant to be myeloma. And that was something that we did as 200 international leaders getting together, redefining what myeloma meant. That was a Herculean effort, and it's now led to what we're going to do in the future. So I'm going to stop there and let Vincent have his full time to come up. Welcome to Emory, welcome to Atlanta, and we're so glad you're here.
Well, thank you so much for having me. It is a real pleasure and honor to be at Emory. I have been here a few times now, and I'm really grateful to Dr. Loniel and the Puri family for inviting me and recognizing me with this lecture. I recognize, like most of you are not myeloma doctors, and if I give you a lecture on multiple myeloma, it will bore you. So what I want to do is really, yes, one thing I will do is to tell the story of myeloma and how the treatments have evolved, and hopefully at the end of it, you will know something about this fascinating disease. And in the last 15 years or 20 years, I don't think there is any other cancer which has had so much progress as multiple myeloma has. And so I would like you to know about that. The second thing I would like to do is that there are lessons we learned, Dr. Loniel, Dr. Ducker, all of us, navigating this field that apply not just to myeloma, but to all other cancers. And there are lessons that other people, those of you working in other fields, other different cancers, can take away from this. And then the title of the talk, which is, there are certain ways we look at things, certain perspectives, certain paradigms that have been established over time. And as we get more information and new information, how do those paradigms change? And if you really think a paradigm has to change, what does it take to change a paradigm? How much work has to be done? What kind of groundwork you have to do to really alter what was previously thought to be the standard? So I will go ahead with that. The first paradigm that I want to address is the disease definition itself, which Dr. Lonial mentioned. If I just say that 90/70 is the normal blood pressure, then I have just literally made the whole United States have hypertension. So I have over the years had a great fascination for how people define diseases. Like you set a cutoff and call this as disease, and you alter it even slightly. You can change the prevalence of the disease. You can change the way people think. Even in the myeloma field, in the Waldenstrom's macroglobulinemia literature, there's a group which defined Waldenstrom's as any level of monoclonal protein with any infiltration of bone marrow plasma cells is called Waldenstrom's, with no regard for symptoms or tumor burden or anything. That makes Waldenstrom's macroglobulinemia the most common malignancy in the country, which it's not. So this fascination with disease definition and what it means to call something what, and as I applied it to myeloma, you begin to think of certain things that all of us realize will need to change. To walk you through this, I want to just spend a few minutes on how we look at this plasma cell disorder, plasma cell malignancy. So we have normal plasma cells. They divide in response to infection, and sometimes a mistake happens, and then you get a clone. And that clone is like a polyp. It just is there. It doesn't grow. It doesn't cause death or anything like that. It's just there. And that is monoclonal gammopathy of undetermined significance, or MGUS. And an intermediate stage called smoldering myeloma was associated with that. Now, we think now that 1 of 5 cytogenetic abnormalities involving the immunoglobulin heavy chain happens, like the IgH translocations, 414, 14, 16, 11, 14, and so on, would be enough to cause a normal plasma cell to become a clonal polyp, or one of the hyperdiploidy changes. But then the polyp just sits there till something else happens that makes it a malignancy that can actually cause end organ damage and cause somebody to lose their life. And that is the transition from MGUS to multiple myeloma, which we think requires a second hit. In most cancers, the pathologist is able to tell you who has the polyp and who has the cancer, because they can look at the pattern of infiltration, they can look at the cells and how they look, and they can tell you this is breast cancer or this is adenoma. And we believe that like gospel. We don't question the pathology. The biopsy result says adenocarcinoma of the stomach. We are not questioning that. That is gold standard. Whereas in myeloma, unfortunately, we were stuck in a situation where pathologists, whether by visual inspection, immunohistochemistry, flow cytometry, molecular analysis, could not tell us who has malignancy and who doesn't. All we knew is there's a clonal population. And so we came up with this idea of CRAB features. CRAB features means hypercalcemia, renal failure, anemia, bone lesions. So it's like a clinical-pathologic thing. If you have a hypercalcemia or bone lesions, then you are called as myeloma. If you don't, you have the polyp. So it was very much different than other cancers. And we also differentiated MGUS and smoldering multiple myeloma. Is this pointer work here? Sorry. Pardon? Or maybe I can just use the mouse. I'll use the mouse. So we also recognize that the rate of progression where this MGUS becomes a myeloma is only 1% per year, whereas there's another group of patients who have a higher risk of progression of 10% per year. So we arbitrarily, it's like calling something a small polyp versus a big polyp. We just called it MGUS and smoldering myeloma, simply to differentiate people who had different risk of having the malignancy over time. So MGUS was less than 10% plasma cells, smoldering myeloma was 10% or more plasma cells. But really, to differentiate cancer from no cancer, it was really all clinical features. If you had bone lesions, that's myeloma. Don't have bone lesions, that's MGUS. Well, there's a problem with that. And that is, if you didn't have any good treatment, it's okay to do that. But when you have a lot of good treatments for the cancer and you can make the cancer really do well over time, you cannot wait for the end organ damage to happen. So we didn't want people to get bone disease, but we were not willing to call somebody as having myeloma until they had bone disease. So then you cannot prevent it. You didn't want renal failure, but you weren't willing to call somebody as having myeloma until the renal failure happened, in which case it becomes hard to reverse. That's a catch-22. That had to change. Thankfully, the myeloma community came together and said, like, how do we solve this problem when we don't have a gold standard, when we cannot separate it? And we said, let's look for biomarkers that if somebody has this, almost certainly they have myeloma. We cannot be 100% sure, but almost certainly. So we came up with, if you have more than 10% plasma cells, that's smoldering myeloma. But what if you had more than 80% plasma cells? What if your whole bone marrow was plasma cells? Is that still smoldering myeloma? And we looked at that closely. What it took was a study to be done at Mayo where we looked at all the patients whom we had called previously as smoldering myeloma and looked at the bone marrow plasma cells. And when we found patients had more than 60%, their rate of progression was not 10% per year. It was more like 40% per year, 45% per year. If I told them that you had smoldering myeloma in January, they will get myeloma in June. So there's no point in telling these people, you have a polyp and we'll just watch you. So we just had to change. What it also took was that it was not enough for me to say this. Somebody else had to do an independent confirmatory study to show that this was true. So that's what we did. We also found similarly the light chain levels. The normal light chain level ratio is like less than 2. If you have a ratio of more than 8, it's not very good. But if you have a ratio more than 100, then, well, lo and behold, you have a high risk of getting renal failure. And calling these people as just smoldering and watching them means that one of these days they'll get renal failure in between your visits. And the risk was about 70 to 80% over 2 years. So we said that this group also should be called. If your ratio was way more than 50, 100 times normal, you should be called as having multiple myeloma. And that was the second change we made. Again, had to be confirmed by another group. And the third one was focal lesions. You can detect lytic lesions only after the bone cortex is destroyed, but you can detect focal lesions on MRI scans even before the bone is damaged, and you can see it on a CT scan or a skeletal X-ray. And we found that if people had 2 or more focal lesions, they were definitely going to get lytic lesions in the next year or two, about 80, 90% risk. And that was the third biomarker that we used. So using these 3 biomarkers and validating it in confirmatory studies, the definition of myeloma was changed to say you don't need symptoms, you don't need end organ damage. You just need one of these 3 biomarkers, either 60% or more plasma cells, more than 100 focal free light chain ratio, or more than 1 focal lesion on MRI, in addition to the CRAB to having myeloma. So it became, instead of CRAB versus no CRAB, the paradigm change was that you just needed myeloma defining events, and you may or may not need symptoms. When you, this paper was then published in the Lancet Oncology, and Dr. Loniel is the author on this paper as well, and more than 200 of us worked on this. And what I learned with this process was that you want to make a change in something as fundamental as what you call myeloma. Number one, it has to be true that the community is willing to accept it. And what we found was that general community practitioners were not very comfortable watching patients with 200 light chain ratios or 70, 80% plasma cells. And so they were really very happy that we are saying, go ahead and treat them. And so the change happened. The colleagues have to agree. So all of the myeloma experts were willing to buy into this philosophy. And so that was really helpful in making the change happen. And thirdly, it's a slippery slope is what I was told. Like once you start saying that you don't need symptoms, you don't need end organ damage, tomorrow someone else will come up with another criteria. And And my answer to that was, it is okay, that is the intent. We want a slippery slope. As you find more and more features that tell you who has malignancy and who doesn't, we are not going to keep sitting on the same definition. We should be willing to evolve with time and be willing to accept that. Anyway, as a result, this paradigm has been changed. We don't need end organ damage now for myeloma. And the current paradigm is this new definition. And this paper has now been cited more than 4,000 times and has become the #1 cited paper in the literature for the myeloma field. The second paradigm is we have a sliver of patients who had high risk of progression that we have taken out, and we've called them myeloma, and now they're getting treated. But that still leaves behind the vast majority of patients that we call as smoldering myeloma, who have this 10% risk of progression every year. They still smoldering, and the dogma or the paradigm was we watch, watch, watch. We just don't do anything. And I had two problems with that. One is that all of the effort with the diagnostic criteria applies to like 5–10% of patients with smoldering. That's hardly any change. That's a small change. I wanted to make a big change. And the second was that these patients with smoldering myeloma included people who had a very high risk of progression. They had a 50% chance of getting lytic lesions within 2 years, and I'm not going to sit on that. It's not my feeling alone. Dr. Loniel had the same feeling. Many of my colleagues, Dr. San Miguel, Dr. Mateus, Dr. Kumar, I can go on, had the same feeling at the same time that this is not good to just leave this whole group as watch, 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 because early intervention could potentially save lives. And when we looked at the natural history of smoldering myeloma, what we found was that about half the patients or a third of the patients with smoldering myeloma had what we call high-risk smoldering myeloma. And they had more like a 25% per year risk of progression. Once they progressed, the remaining patients, like you take 100 people with smoldering and 2 years go by, let's say the first 50 have progressed. What you're left behind is mainly MGUS. And they have a risk of progression which is very, very low, 1 or 2% per year. So we said, like, if we knew who's who, then, then we can really make the change happen. And the main paradigm that changed was when Dr. Kyle and Dr. Greip in the 1980s came up with this term smoldering myeloma. It was more of what they envisioned was there was MGUS, there was multiple myeloma, and there's something in between, like a smoldering entity that's an in-between stage that people get MGUS and they become smoldering and then they get myeloma. What the paradigm change was that what we call smoldering myeloma was really not something smoldering in between, but it was really a mix of patients, some of whom had MGUS and some of whom had the full-blown flame. We just didn't know who's who. If you know who's who, then we wouldn't be calling all these patients smoldering. At this point, we still don't know who's who. If you take 100 people with smoldering, probably 30 or 40 are the flame, about 60 are the embers, and we don't know who's who. And people like Dr. Dodapkar are identifying ways in which we can tell the two apart, in which case we don't need the biomarkers and others that I'm going to go with. But what we have found is you can identify most of these people who will progress within 2 years by very simple criteria. If they have a large M protein, more than 2 grams, if they have more than 20% plasma cells, if they have a light chain ratio more than 20, which is 10-fold higher than normal, they have a 50-50 chance of progressing within 2 years. And so these are the people we want to intervene because the others have a very, very low risk of progression and we don't need to do anything about them. This has been validated subsequently by the International Myeloma Working Group. And as you can see here, there's a 50-50 risk of progression at 2 years, and about 1/3 of patients with smoldering myeloma have this problem. And this is the group that then, this is not enough to say you need to do early intervention. You have to do randomized trials. And the randomized controlled trials have been done which show that if you take patients with high-risk smoldering myeloma and give them just simple oral therapy with lenalidomide and dexamethasone, you can reduce the risk of end organ damage substantially and also improve the overall survival. And this study was conducted and published in 2013, but it still didn't change the paradigm for early intervention because everyone wanted one more confirmatory trial. This confirmatory trial was led by Dr. Loniel, and it was published in JCO, where we use only lenalidomide. And we found that if you take these high-risk patients, there was a 90% reduction in the risk of end organ damage by treating them with just simple lenalidomide for 2 years. As a result, right now, our paradigm for early intervention has changed to the point where if there are myeloma-defining events, that's clearly myeloma. If they have none of the high-risk features, that is clearly somebody you watch. But if the 1/3 of patients who have high-risk smoldering myeloma or they evolve to a high-risk pattern, we are, at least me, Sagar, and many of my colleagues, are recommending early therapy with lenalidomide and Lendex, and we are doing so confidently. So confidently that currently the ECOG trial that we have going on in the US has treatment in both arms. So the NCI and everyone's agreed that early intervention in the high-risk group is worth it. So the first paradigm change was a change in the definition. And the second paradigm change that we were able to accomplish with all of our colleagues' help is this early intervention for patients. The problem anytime you say early intervention is that all these patients are only accidentally found because smoldering myeloma is asymptomatic. So you're telling me that you can intervene early and delay or prevent end organ damage in 90%. They may even live longer, but we can't find out who's got smoldering myeloma because we are not screening anyone. We are not recommending screening. So it's by chance you find smoldering myeloma, then you apply this criteria. But if you never find it or you never test for it, you don't know about it, and the paradigm just continues. They will be diagnosed as having myeloma only after they get bone lesions or things. So how do you solve that problem? Screening is not something I take lightly because screening the general population for a disease carries a lot of problems with it. You're going to give them a diagnosis that they didn't want to have, and you need to be able to show that you have a good test. You need to be able to show that doing that test early is going to save lives or prevent some problems. And otherwise, you generally don't recommend screening. That's why colonoscopy or mammography took large randomized controlled trials before we start using them in clinical practice. MGUS is a very, very common problem. The prevalence of monoclonal gammopathies in the general population was studied in Olmsted County by Dr. Kyle. What Dr. Kyle did was, in Olmsted County, a very small area, you can actually, everybody comes to the Mayo Clinic and you will get the samples from everyone over time. So over 3 years, everybody living over the age of 50 eventually comes to Mayo and eventually gets a blood draw. And if we just capture a small amount of those people's blood, then we can test it and find out how many people have MGUS. And that's what we did. Of the 28,000 people living in Olmsted County, 50 years or older, 22,000 ended up going through Mayo Clinic in a 2 or 3 year period, and we found that 3% of them had a monoclonal gammopathy. With a more sensitive test, we are able to now say that about 5% of the general population, that means 1 in 20 of us here, has a monoclonal gammopathy over the age of 50, of course. That's a lot of people. And you don't want to do a screening test on the United States to find that 1 in 20 people have MGUS and then subject them to a bone marrow biopsy or follow-up unless you're sure that doing so will save lives. So we are not ready for that. The Iceland group, Sigurdur Christensen and his group, have done what I thought was impossible, which is to randomize an entire country, all the people 40 and over, to screening. And one group is screened and they never told the diagnosis, they go about their lives. The next group is the next group 2 is screened, and if they are found to have MGUS, they are told about it, and they follow currently what our guidelines are, once a year follow-up. And the third group is followed more closely every 3 to 4 months to see if early intervention will help. Again, I think the Iceland population over the age of 50, I think Sigurdur told me is like 150 or 140,000 people, and he has sampled more than 80,000 people in Iceland and randomized all of them. And we're getting some really interesting results already. He has shown the prevalence of smoldering myeloma to be about 1% or something, published in Nature Medicine. This is going to be the mother of all studies. You're going to have papers coming every year, 5, 10 papers from the study. But this is the type of study that is needed for me to recommend screening. If this study shows that screening saves lives, then we do screening. If not, we don't do screening. But then there is also racial disparities, because that study will take another 5, 10 years to read out whether screening is useful or not. So are we going to wait the entire 10 years before doing anything? Or are there high-risk groups that I can use or justify screening to right now? If you look at multiple myeloma, I think unlike any other cancer, you would take racial groups and you can find a 10% higher risk of one cancer in African Americans versus whites, or another disease might have 20% higher in whites compared to African Americans. But you never rarely see in a cancer 100% higher risk or a 200% higher risk of a cancer in one group compared to the other. The only disease like that is myeloma, and like another one would be prostate cancer, where African Americans have a 2 to 3-fold, like 100, 200% higher risk of getting myeloma compared to the white population. This is due to, not because the MGUS progresses faster to myeloma, but it's due to the fact that they have more MGUS. The prevalence of MGUS in the general population is 5%. It'll be 10% in the African Americans of the same age and thing. And it also starts earlier. When we look at multiple myeloma, the disparity between African Americans and whites is about 2 to 3-fold in people over the age of 50. But when you come to younger and younger age groups, the disparity is even wider. So if you take people 30 and 40 and less than 50 years of age, the risk of myeloma in African Americans is 3 to 4-fold higher, like much higher. And they're also the group that doesn't have access to care as much and will definitely end up with lytic lesions, end organ damage much faster, and you'll make the diagnosis late as well. So keep that in mind. We also find that the risk of having an MGUS in 40 to 50-year-olds in the white population is only 0.5%. That's only 0.5% of whites have MGUS in that age group. But by 40 to 49, 3.2%, like 6-fold higher number of blacks have MGUS. So this is a very important consideration to keep in mind. The other group that is at high risk of having an MGUS is our first-degree relatives of family members. We know now in many cancers there is a familial tendency. It is not to the level of an inherited classical autosomal dominant or recessive condition where you have a 25% chance of something, but this is a higher risk. It's 2 to 3-fold higher, and it is another group that we need to keep in mind. So keeping this in mind, and I've just gone out on a limb on this, and I think I welcome feedback, but the paradigm I hope is changed or changing, and I hope with the help of Emory that we can change, is that we should advocate screening for certain ultra-high-risk patients. So this is a commentary I wrote in one of the journals, Nature, I think, on the screening imperative, where I argue that for the general population, you should not be screening till the Iceland study comes out. For the high-risk population, you should be enrolling in studies like the PROMISE study, which are looking at screening and the effect of screening in high-risk groups. But for ultra-high-risk group, that is African Americans who already have a 10% chance of MGUS, and if they have an affected relative, that will double that to maybe 20% chance of MGUS or thing, that group we should consider screening, because if we find smoldering myeloma in that population, we may be able to offer early intervention. Similarly, first degree, if you have one first-degree relative with myeloma, okay, but if you have 2 first-degree relatives with myeloma, I think we should be offering screening to those people with informed consent, of course. And the goal would be to identify smoldering myeloma patients whom you can offer early intervention. The fourth paradigm that I'll talk about is, and this has been something that has bothered all of us for a while. Myeloma is a rare disease. It's 1% of all cancers. And we are having trouble doing clinical trials in myeloma because, you know, it's hard to accrue patients in a rare disease. And, but unfortunately, myeloma is not one disease. Myeloma is actually minimum 6, if not more than 6 different diseases that we call myeloma only out of convenience. It's like the McNamara fallacy. We cannot possibly do a study for each one. So let's just forget that it's important and just call them all as myeloma and treat them as such. But a 414 myeloma is as different from 1114 myeloma as CLL is from mantle cell lymphoma. It's like two different diseases. But we collectively call it myeloma just because it's a plasma cell neoplasm. But I think the paradigm that we are proposing, and this is a paper that Dr. Kumar and I wrote in Nature Reviews calling it the multiple myelomas, is to really classify them as at least six different diseases. And the goal would be that we need to put our research efforts in identifying the natural history, the prognosis, the response to therapy outcome, and the mechanism of pathogenesis for each of these as if they are different diseases, because pooling them and studying them will only give noise, and then we won't be able to answer the question of what causes MGUS to become myeloma, because it's not the same for 414 MGUS and 1114 MGUS. They're like CLL and mantle cell. There'll be different drivers, and unless we look at it as different diseases, we cannot get that answer. Thankfully, again, I would like to think this paradigm has changed because both the WHO and the new another pathology group had a different classification. They both agreed to publish this classification in their blue book and everything else. We want to see if we can classify and start expanding databases to consider these different subtypes. The next one I want to talk about is the risk-adapted therapy. Clearly, we always do risk-adapted therapy. We always give certain treatments to older patients that are different than younger patients. We all take risk into account, performance status into account when we decide therapy for any cancer, but that's not what I'm talking about. What I'm talking about is biologic risk, the aggressiveness of the myeloma. Because a person will change what treatments they're willing to take depending on how much risk they have. If you tell me I have a median survival of 10 years, there are certain treatments I'm willing to take. If you tell me that I have a median survival of 2 or 3 years, I would be willing to take on more risky treatments that are more unproven because I want to live a much longer period of time. So our counseling to our patients is their tolerance for risk changes, their plan for their life and how to live their life will change. And we also can make progress if we look at patients in a risk-adapted manner. So this is the risk stratification we currently use. About 60–70% of myelomas are standard risk, trisomies 11, 14, 6, 14. But then about 20–30% of myelomas are high risk. And these are these 5 subtypes, as well as people who have 2 or 3 hits. Now, I'll use this opportunity to go through treatment of multiple myeloma. Treatment of myeloma is right now, we use a triplet induction, either bortezomib Blendex or daratumumab Blendex. Both of them are really good treatments. With these treatments, patients don't even know that they are taking chemotherapy. If you start them on a treatment today, the next time they'll have a problem would be 3 or 4 years down the road. So these are really good treatments, and we use them routinely. But rather than one size fits all, the risk-adapted approach is, can we treat certain patients more aggressively than the data would suggest at this point, at least from randomized trials? So we have data now that if you add a 4th drug, and that's not done lightly because when you add a 4th drug, you're definitely adding toxicity. A drug like daratumumab adds another $100,000 to $200,000 extra cost a year. You don't want to do it lightly, so we don't have the evidence to justify it for every patient, I think. But we have randomized trials that show that the MRD negative rate is much higher with adding the 4th drug, and in high-risk myeloma in particular. So one idea is to do a quadruplet induction for high-risk patients. Another one is changing the maintenance therapy. We always do, myeloma is a chronic disease where we give some initial therapy, maybe a transplant, and then put patients on some drug to suppress the clone coming back. That's lenalidomide, shown in randomized trials, meta-analysis, and everything to be life-saving. So we do that routinely. But the question is, can you do something more beyond the data for high-risk patients? And actually, I think one of the studies that changed practice is the Emory study, where Dr. Loniel and colleagues, Dr. Joseph, Nuka, had the idea that we should be doing doublet maintenance for all the high-risk patients. And so they published their experience with 1,000 patients. For the standard risk patients, they just gave induction, transplant, and Len maintenance. That's the standard of care. But for the high risk, you went above the data, well above the data to say we're going to do doublet maintenance, bortezomib and lenalidomide. And what was a 2-year progression-free survival and 3-year overall survival is now like 7-8 years in the Emory cohort for the high-risk patients. So risk-adapted therapy, thankfully, is here to stay in myeloma. We have all embraced this, that the idea we don't treat everybody one size fits all. We treat standard risk patients differently than high-risk patients. The Canadian group presented at ASH exactly the same data with their approach. Again, standard risk patients now have a median overall survival of 13 years in the transplant-eligible population. High-risk patients about 7 to 8 years. So great advance. And again, this risk-adapted strategy is, I think, here to stay. This is kind of like a summary of how we treat myeloma in the newly diagnosed transplant-ineligible standard risk. We just give initial therapy followed by Len maintenance. In the high risk, what you did here with the 1000 is what we are doing right now at Mayo as well with the doublet maintenance. Same thing for transplant patients. And again, I won't bore all of you with the algorithm for treatment of multiple myeloma, but the fundamental change here is this. And we're also thinking of doing the quadruplet for the induction. The next paradigm I think I want to go into is response-adapted therapy and minimal residual disease. We are really, as I mentioned, the progress made in myeloma is just stunning even to me. When I entered the field in 1995, when I joined fellowship 98, when I got recruited, we really had only melphalan and prednisone for the 50 years prior to that, without any other treatment. And then the complete response rate was 3% with any of these treatments. Maybe with a transplant, you'll get to 5-10%. But now we are getting like 50, 60, 70%. Every time I read a study, somebody is getting a higher and higher CR rate, almost everybody in CR, or you can take relapse patients and put them into CR or complete response with our modern therapies. So we have become into this position of being able to look for 1 in a million cells in the bone marrow. That's the minimal residual disease. And if we can treat patients and get them into what we call MRD negative or minimal residual disease negative state, they have a really outstanding prognosis, and we have embraced that as a prognostic marker that we can use to counsel patients. But the question is, can you use it as a goal of therapy? Can you drive patients to this MRD negative status as that is your goal, or as a surrogate endpoint for drug approval, or as a marker of cure, remains unproven. And this is the paradigm that we want to change with many of the trials we are doing. Just one example of a trial here where we are looking at MRD assessment and randomization based on that. In Europe and other countries, they're having multiple randomized trials going on. And the whole goal would be to guide our intensity of therapy and our goal of therapy based on the MRD status, which is something that we were not lucky enough to do until this point, but the paradigm has shifted. In fact, for high-risk patients, many of us already feel like we should be shooting for an MRD negative state as much as possible with our initial therapy. The SWOG maintenance trial goes the other way around and asks, once somebody is already MRD negative, can we stop the treatment and just give patients a treatment-free interval? And that would be the other way of looking at it. But response-adapted therapy, which we have never done, we've usually done either a fixed duration or we have just done indefinite till progression. But this idea of adjusting the duration and the intensity based on MRD assessment is a major paradigm change in the disease. Immunotherapy, you know, again, when I entered the field, and I'm sure Dr. Loniel and this, we've gone through from IL-6 antibodies to dendritic cell vaccination to various treatments that we all thought would change the course of the disease, but did not pan out. They didn't really deliver what we thought in terms of response. But I think finally we are able to announce that immunotherapy has really taken off in multiple myeloma. It's become a major, major advance for us. And two big areas. One is CAR T cells. CAR T cells now, there are 2 of them approved for multiple myeloma. And while they are not curative, as they are in acute lymphoblastic leukemia or diffuse large B-cell lymphoma, they do prolong life in patients for whom we didn't have any other treatment options. So this is a study, patients that exhausted all their treatment options, published in the New England Journal. You can see once they started CAR T, another 2 years of life with about 1 year of progression-free survival. And with the second CAR T here, at 2 years, 75% of patients who are alive and 65%, 60% free of progression. So we have really given a huge extra 2 years of life beyond the 13 years and everything else that I mentioned to you for multiple myeloma patients, all in the last 2-3 years. And we are all doing this. Emory is doing CAR T cells. We also have another treatment that we have right now called bispecific antibodies, and they also have produced 60% or higher response rate. Multiple bispecific antibodies are available for myeloma right now, one of which, teclistamab, is commercially available and approved and is being used, I think, at Emory and at Mayo. Every week, patients are getting treated with teclistamab, again, offering extra thing. Sooner or later, we're going to end up with patients who have exhausted all options, including CAR Ts and BCMA-specific bispecific antibodies. But we are confident that newer bispecifics and immunotherapy will come to the rescue again with bispecifics targeting antigens besides BCMA as one option. Same thing with CAR T. So I think the idea that we had that immunotherapy will not be effective in myeloma has changed to the point where now we rely on immunotherapy for our relapsed refractory patients. The final thing that I will mention, and then I'll close and be open to questions, is cure. Cure to me means not just living out a normal lifespan. You have to do it the old-fashioned way, like Dr. DeVita. You have to give a finite duration of therapy, stop the therapy, and the cancer never comes back, and you are not taking chronic suppressive therapy. That is true cure, and that's what we are going for. And unfortunately, in myeloma, that has been so elusive. It's very, very hard to find any series where there is a plateau. Patients need to be on continuous therapy, which is more like a chronic suppressive therapy rather than a true cure. It is possible, as I was discussing with other people here, that myeloma is a cancer of the immune system itself, cancer of plasma cells. These cells are the whole evolutionary thing is they are there to defend us from outside insults. It's not easy to get rid of them. We have seen how you can give 200 milligrams per meter squared of melphalan and the whole marrow is wiped out, but the plasma cells are still there and they still come back. So it is possible that myeloma is not a curable disease because the nature of the cell is like that. If that's the case, I don't think we can do anything much about it, but I'd like to think that's not the case. I'd like to think that myeloma is a curable disease, and the reason we haven't cured it is either because we didn't have the tools. Well, we now have the tools. You can see we have multiple drugs that are effective. We didn't know how to use the tools effectively. Now that we have the tools, there is a whole series of trials, and I'm sure Emory is also doing one, where we are putting these cocktails together in powerful combinations for 1 or 2 years and stop. And the whole idea is, can we cure people? And those trials are, and of course, each institution in the US and in Europe and other places are going to do a different cocktail, a different combo, but we are all embarked on this idea of finite duration therapy, stop, and the disease never comes back, and try to put your cocktail together and do multiple parallel phase 2s to see if we can cure the disease. So we have the tools, but we don't know how to use them well. Let's all combine collectively in parallel, figure out how best to use. So that's one way potentially we can cure it. The other way we can potentially cure it is, what if cure is not possible in myeloma only because we've been not treating the disease at the right time? What if myeloma is actually curable if you hit it early, like before the end organ damage, when the disease is at a more susceptible stage, when the cells are more vulnerable to treatment? And so that's the idea behind the smoldering myeloma trial strategy, where Again, many of us are doing these regulatory type studies with one or two drugs or the delaying progression, but in parallel, we have embarked on trials where we are really going very aggressively in the smoldering myeloma stage before end organ damage with all the tools we have. And the two of these trials have already been completed. There are more planned with, and the whole idea is the reason we haven't cured myeloma is because we are treating it once metastatic disease has already happened. And if you hit it at the smoldering stage with whatever tools we have right now, we will probably be able to cure the disease. And that's a paradigm that has not been changed. That's one of the things that I mentioned is an aspirational one. It's something that I hope we will change before I retire or Dr. Loniel and others retire. Thank you so much for your attention.
We'll start off while people are warming up. So you mentioned Cesar and Ascent. The curves of relapse look like myeloma relapse curves. So how confident are you that treating aggressively early will actually change the natural history of the disease, as opposed to just starting the clock sooner?
I'm not confident. I told you one way of curing this is one way why we have not cured the disease, maybe because we haven't started at stage 30. But Cesar and Ascent, the curves just show that this kind of approach may not be enough. We may need to do more, like CAR-T or immunotherapy early to actually accomplish what we're looking for. It's also possible, Sagar, that the curves are coming down, but they may plateau at some time point. Both Cesar and Ascent start the therapy, and then we continue to see some patients relapse. But it's possible that at say 30–40% they plateau and then they stay the same. And that's important because historically, this same cohort that Dr. Mateo treated before, all but 2 patients are progressed. So we know the natural history is supposed to be like this. And so even if you see a plateau, even at 30 or 40% down the road, then we know potentially cure, and then we can start working on how to improve the plateau. Time will tell.
Yeah. So really great talk. Thank you. Multiple myeloma, I think about the multiple part of it, of multiple sites of disease. If the transforming event in myeloma occurs in the germinal center, can we use deep sequencing to look at the presence of passenger mutations to understand how many different sites are seeded in the initial, after the initial transforming event, meaning one germinal center, one transformed cell, local daughter cells in the lymph node, go to the bone marrow? Is that 10 sites? Is that 100 sites? Does the myeloma go to one place and then recirculate from the bone marrow to additional sites?
So the malignancy in most patients starts in the bone. So the clonal event is.
So it presents in the bone marrow,
Yes.
but if you look at immunoglobulin chain rearrangement as part of the defining event of myeloma, that doesn't, class switching doesn't occur in the bone marrow. It occurs in the lymph node.
Exactly. So the first MGUS stage where the IDH translocation occurs in the lymph node, then the cells migrate and they establish a polyp-like state in the bone marrow, maybe elsewhere, but they stay there. But when the malignant event happens, which is beyond the IDH translocation, there's got to be some other event that happens that transforms this IDH translocated cell, which has been sitting there for 50 years or 40 years, into a malignancy. That process, we think that most likely happens in the marrow, but we cannot be sure. But once it happens, then it sees the various parts. And what we see, both the bone marrow studies as well as studies where people have sampled different parts of the thing, is that the disease from the beginning is multiple clones that are daughter clones of the original parent clone. And these clones are there from the beginning. And over time, there's like these clonal dominance. One clone dominates, but the others are malignant, but they're still there. And then another one takes over and you eradicate this, and so on and so forth. So, but in the studies, the patient finally succumbs to a clone, right? You sequence that clone, that if you go back 5–10 years earlier, was there at the very beginning. except at a very, very low level. So you're right, I don't know where when the malignancy happens, whether it happens in the marrow first or it stays at somewhere else, but I think it's in the marrow. But once it happens, and the cell acquires the ability to go elsewhere, then it goes and sets shock, and there a mutation happens to the point where they are slightly different from each other from the beginning, even in the newly diagnosed.
Can you distinguish the clonal progression from one event in the marrow from the alternative hypothesis would be dissemination from the lymph node of many pre-myeloma clones that then stochastically become myeloma at different sites at later times?
No, I'm not sure about that. But one of the things that is really fascinating about myeloma, which is why I'm thinking the first IgG translocation happens and you get an efflux or try to believe that you get an efflux. From that point, the transformation event is stochastic. It is basically random chance because the risk is fixed over time. No matter how many years go by, the next year the risk is only 1%. So it's not an event, and that event can occur here or here. It can happen anywhere where the cells are and these cells are. But what happens at that point, it then migrates to other places and sets up shop.
Go to the back and then.
Yeah, really great talk, thank you. So sort of bouncing off of your question. So I can understand and appreciate where you're coming from about like identifying, like not really being able to trace. So like you're describing sort of like a lineage tracing experiment, but in humans. So I don't know very much about myeloma, but do we know what the like the first bone marrow location where that stochastic event occurred? Like, can you determine that in a human?
For the transformation from indus to myeloma?
Yes.
So, normally we are just sampling a random area of the bone marrow in the iliac crest because that's where, in that age group, a lot of marrow is located. And we usually see it there. That's probably not the only place where it happens. So the initial response to the infection and the establishment of the clone probably happens in the lymph node. That's where the IgG translocation happens. And that still explains we have the embryos, the remaining half of trichomes, and I don't know how the pathogen is there. But let's say the IgG translocation happens. Then the cells do go to the bone marrow, those translocated cells, because we can identify them as embryos on a random bone marrow. IgG crest, it's there for the embryo. So even if it starts in the lymph node, it does spread everywhere and it sets up, but it stays there. Why? The next event where it happens, where it progresses from embryo to myeloma, similarly can be just about anywhere. But I think again in the marrow somewhere, because that's where these cells are formed and stayed on.
So once that does occur, are there have we been able to identify differences so we have multiple myeloma and it's starting to spread everywhere. Are there differences in distinguishable mutational differences of the cells in the plasma and the bone marrow, and then in other locations where it's spread and metastasized?
Yeah. So there are probably two kinds of differences. One, I was just talking to Dr. Dodavkar, macroscopically, there might be differences in how the cells which are clonal but not malignant assemble versus clonal and malignant assemble. And so far, we haven't been able to identify, but maybe now with more like AI type of process, you might be able to tell who's who. Which are pathologists and by visual inspection, we haven't been able to determine. The other thing is the mutational thing. That's where it's really fascinating. Over the years, we haven't found a consistent set of patterns that truly differentiate the pre-malignant from the malignant. And that's whether by genetic profiling or whatever type of sequencing we have done. And part of the reason that I was talking to Ben this morning, part of the reason might be because we are grouping 5 or 6 diseases together. And we're looking for the same kind of event that separates 11-14 pre-malignant from 11-14 malignant, and then mixing it up with hyperdifferent. So I think the key to finding the difference would be to start looking at each one as a different disease. And then we probably find a signature that clearly separates 1114 malignancy from 1114 abscess.
This is more of a philosophical question. When you talk about screening, right? Typically, when we screen for cancers, we want to detect early because there is a curable opportunity when you detect early. And by screening, you're able to pick that up. In your situation, when a cure is still not in hand, how do you guard against over-treatment if you start screening?
Right. And so, early therapy or screening can be justified not because there's only a curative option, but at least if you can prolong overall survival or reduce significant morbidity. Significant morbidity in myeloma is primarily renal failure or lytic bone lesion. If you can prevent those or delay those, that I think would be a reasonable reason to intervene. When we say intervention, the intervention we have is might enough that in Dr. Lodia's study, which started in 2003, after a year or two of therapy, there were 6 patients who have died in the whole study itself, and only 2 in the lenalidomide arm. So we don't think you're giving any toxic treatments to people. You're giving treatments that are mild enough that you prevent end organ damage. And with screening the ultra high risk group, the ones that I mentioned, African Americans with one affected relative or whites with 2 affected relatives. If you find more, it still doesn't mean you need to intervene. That intervention can simply be following them every 2-3 months close. And so I think there's a grade in terms of the intervention and how much risk we are willing to take. For the type of interventions, either frequent observation and then alone, I don't think the survival benefit is absolutely needed. Preventing renal failure or bone lesions might be reasonable enough. It's again, but it's a philosophical point where you draw the line.
Thank you for that. Really the fact that the multiple myelomas, I completely agree with you that the only way we're really going to learn a lot about them is not to lump them together that way. We know that there's differences. I know my pathologist friend over there, Dr. J, would tell you he can look at cells and tell you if they're 1114 because they're even morphologically different in cases. And so there's obviously differences there. However, when you went to your last, so I'm going to bump that against your other paradigm shift, which is that last one about the cure. And your rationale for some of these trials is the idea that we have this great toolbox now of really effective therapies, and that we could probably, if we put them together in the right way, we might be able to achieve a cure where you don't need maintenance. However, almost all of those therapies that you talked about wouldn't fall into the multiple myelomas sort of idea, because the reason they were so great and have 60% CRs is because they actually affect all of the myelomas. And so I think we have to be a little careful or cautious in thinking about the multiple myelomas exclusively, because our best way to get to the cure right now that you're talking about were drugs that actually target all of them.
No, I think what right now, other than venetoclax 1114, you're right. The drugs we have work really well in every single one of these categories of myeloma. So in that sense, you are right. But if you step back and say, if you give hard CHOP to follicular lymphoma or diffuse large B-cell, both will respond. One will be cured, one won't, but both will respond really nice. That's where I'm coming from. It's like it's possible that one or more of these subtypes can be cured by a certain approach. And rather than saying it's not curable, let's approach it in a different way. So one way is to treat symptomatic myeloma patients with, in parallel, each center taking their own curative approach. If we have to transplant maintenance to the standard, okay, Dr. Lodia says I'm going to do really CAR-T and bispecific maintenance. Let me see if I can do it. Meanwhile, maybe we say I'm going to do Delavier plus transplant and then bispecific maintenance. Let me see if I can do it. If 10 of us do 10 parallel trials, it's possible that we have a combination that is potentially curative in one or more subtypes. The other idea is, like I told you, it's possible one or more subtypes can be cured if you intervene early. With, again, I don't know how successful we are with what we call the cocktail went with, which is the myeloma treatment, ERC transplant maintenance for ERC. Maybe it requires more than that, but the idea again is the same, that one or more subtypes might be curable and you just have to wait. Problem with cure is you start therapy and years have to go by before you know whether you've cured somebody or not. And thankfully, these trials, both Ascend and Caesar, were started years ago. I'm just urging people to start these trials because it will take 10, 20 years to read out. And if we don't finish them now, you won't have the follow-up to answer that question.
Yeah, I think the hard part though is that we all have patients who are not on the have 8, 10, 12-year remission and relapse.
Yeah.
And so there isn't that 5-year cutoff that most
Yeah.
solid tumors have to say, if you're 5 years disease-free on no treatment, you're cured.
Yeah.
That may not apply to plasma cell disorders. So the cure, the definition of cure is going to be the key part, not the cure.
Right.
All right. Yeah. I'll get the last question. So the activity of body.
It suggests that the unengineered immune system can recognize and kill myeloma cells. So in that context, why don't you think immune checkpoint inhibitors have shown activity in this disease?
Yeah, I don't know why, because we were all hoping that it would be the case. And it's so fascinating, right? Like you have, I think, I'm not very familiar with Hodgkin's disease, but I think it's one of those diseases where immune checkpoint inhibitors have done really, really outstandingly well, even in some other solid tumors. But in myeloma, the trials went completely flat. Like we hypothesized one thing, and then you find the exact opposite. No difference in PFS or overall survival. I don't know. I don't know what is so unique about the plasma cell that it's not vulnerable to something like this. Yeah.
All right.
Oh, yeah.
Hold on 1 second while we have Dr. Puri come back up. Okay. All right.
She has to accept it though.
Cynthia, come on, you're coming up. You're coming up. Yeah.
Dr. Rajkumar, thank you so much. And this was not family to you.
Okay.
Thank you so much. I really enjoyed it. We were right yesterday. I could get some. The way you presented it. So nice. I hope you come back. Give it up and